So hope everyone can see my slides, and I'm just gonna maximize here. There we go. So this is part of a curriculum that we have set up in South Florida, some of the didactic content that I'll go over. We visit EMS stations in our county, Broward County and North Miami-Dade, just about on a quarterly basis to teach, especially new recruits, paramedics, on stroke care advances, pre-hospital assessment, and challenging scenarios, illustrative cases. So they find this really helpful in terms of understanding, the information we would like to hear from the paramedics when they call in a stroke alert, some of the objective, information from using the race scale, as well as, for patients that may have a prior history of stroke, how to go about communicating, a stroke alert in those situations as well. So this is an overall outline of what I'd like to go over today. And again, feel free to ask any questions along the way. So in terms of stroke basics, I'm sure most of you, given your experience evaluating possible stroke patients in the field, have been taught this already, but just in case, the vast majority of stroke patients that we see in the hospital are those that have a blockage of an artery in the brain, and that's the left-hand side, the ischemic stroke. Ischemic means that there is tissue in the brain that is being deprived of oxygen due to a blood clot. And so that could be a small artery in the brain, what we term some of the lenticular striates or perforators, the smaller branches that arise from the major branches, the large vessels. And the overall causes of, these types of strokes are no different than heart disease. So smoking, high blood pressure, high cholesterol, diabetes, all of those also lead to vascular issues in the brain, just like in the heart, resulting in a heart attack. What we call a stroke is a brain attack. And so almost 90% of all strokes that we see in the hospital are due to blockages of arteries in the brain. And then the remaining about 10 to 12% are due to bleeding in the brain. And what many people, in the community may not know is that bleed in the brain is also a stroke. It's what we call a hemorrhagic stroke. And that could be due to, again, high blood pressure causing a rupture of an artery in the brain, especially the smaller, more friable blood vessels. It could be due to rupture of an aneurysm or other vascular anomalies, abnormalities, such as arteriovenous malformations. And so I'm not going to go into detail about how we manage those types of patients in the hospital, except to say that many times the ischemic and the hemorrhagic patients, that may be having stroke-like symptoms present very similarly. And in the field, it's, many times hard to tell whether it's a blockage of an artery in the brain that's causing a stroke or bleeding in the brain. But I'll go over some of the differentiators just so it's easier to at least go down the potential pathway of, okay, what this patient might be suffering from and how to appropriately triage that patient to the appropriate stroke center. And so in terms of patients that have blockage of artery in the brain, the major blood vessels is what we call large vessels. And those are the arteries in the brain that are kind of like highways. And so imagine, the carotid arteries or the arteries in the back of the brain called the vertebral arteries. So you have four main arteries that supply blood flow to the brain, the two carotids in the front and the two vertebrals in the back. And essentially, the vascular territories are divided as such that the carotid arteries, which are, what's demonstrated here, supply flow to primarily the front of the brain, about 2/3 of the brain. Each hemisphere, the right hemisphere has a right carotid supplying it. The left hemisphere has the left carotid artery supplying the front of the brain. And those are the sort of stroke signs and symptoms that are most reliably assessed on the race scale when there's a stroke that occurs in the front of the brain, what we call the anterior circulation. What's not seen here are the vertebral arteries, and I'll go over that in different case scenarios. Are the ones that supply the back of the brain, what we call the posterior circulation, and they primarily supply the brainstem, the cerebellum, and it's essentially, very precious real estate, what keeps us awake, alert, alive. A lot of our autonomous functions, such as, our heartbeat, heart rhythm, our involuntary breathing, our respirations. So that's vital to keeping us alive. And then the cerebellum is for balance and coordination, right? So, kind of making sure that when we're out and about, that we have good hand-eye coordination, that we are maintaining our balance, able to walk in a straight line, and so forth. And then the occipital lobe, which are the two areas in the back of the brain that's responsible for our vision. And so that's also supplied by the posterior circulation. And so when a patient first presents to the hospital, to the emergency room, let's say triage, transported by paramedics, what we're really worried about when there's a suspected stroke and we're emergently doing a CT scan is how much of the brain is already damaged versus how much is at risk for irreversible injury as time elapses. So, for example, what this is showing is every time a artery in the brain is experiencing a blockage, right? So especially a major blockage, what we call a large vessel occlusion or LVO, immediately the neurons downstream are being affected. So imagine, as I alluded to earlier, you have the major arteries that are the highways, and then you have the smaller arteries that arise, which are the side streets. And so when there is a blockage, the downstream neurons are immediately being affected. And then those that are farther away might be receiving bypass collaterals from arteries elsewhere in the brain, working in reverse fashion, supplying blood flow, to some of these neurons, farther away. And that's really what we want to prevent from getting permanently damaged, right? And so how can we do that, is what I'll go over next. But imagine, every time a stroke is happening, it's like a wildfire in the brain. And our goal, time is of essence, is to stop that wildfire from spreading as quickly as possible so that the patient can get back to a meaningful quality of life. And so the different causes of how these blockages of arteries in the brain can occur, the most common is the cholesterol plaque, being deposited within the arteries in the neck. This is a very common cause as all of us, age, especially folks in the 60s, 70s, 80 years of age. Just like, as I mentioned earlier, for heart disease, you have plaque buildup for the main tributaries, the, arteries that go to the brain. And so many times, if a patient is experiencing a stroke, one of the first things that we want to evaluate using our vessel imaging studies in the hospital are the arteries, the carotid arteries in the neck, making sure that they're fully open versus, do they have significant stenosis that we have to go in and open up. Another cause is atrial fibrillation. And so that's the irregular rhythm within the heart, the atrium of the heart. So every time the heart is pumping, we want that rhythm to be regular so that blood is not just hanging around within the chambers of the heart. But when it becomes irregular, the rhythm, it causes stasis of blood within the chambers of the heart, the atria, and then that predisposes them to forming blood clots. And then during the next heartbeat, for example, invariably that blood clot can dislodge and go all the way up to the brain and cause a blockage of an artery in the brain. And this is very common. I would say about 20%, so 1 in every 5 strokes that we see are due to atrial fibrillation. And so it's something that we work up once a patient gets admitted to the hospital. Initially, we may not know what the cause is, especially if all the arteries look open. So one of the suspected causes could be atrial fibrillation. And so the way we work that up in the hospital, or the way you might pick that up in the field, is when you're doing your EKG and on the telestrip, you might see that the patient is actively in new onset atrial fibrillation, and that may very well be the cause of their stroke. And so we've made some significant advances over the past, 10, 15 years in terms of how we can manage these patients. That's why we're discussing, this with you all for pre-hospital stroke care, because prior to, let's say, 15, 20 years ago, there wasn't much we could do for the most severe strokes, the large vessel occlusions. The only therapy that's been available up until say 2014, 2015 was the clot busting medication IVTPA. That was approved by the FDA in 1995, but the limitation is that it can only be given up to 3 hours, and more recently up to 4.5 hours after time of symptom onset. So the vast majority of stroke patients, by the time they come to the hospital, if they had the worst case scenario, large vessel occlusion, then there was nothing we could offer those patients, especially if they're out of the time window. So this relatively new therapy, and what has revolutionized our field, is what's called mechanical thrombectomy. So I'm just going to show this animation of how this works. And so this is a treatment that's performed in the cath lab when the patient arrives to the emergency room. And if we have the actionable information from paramedics, we're able to act quickly, mobilize our cath lab teams, just like how cardiologists are able to intervene for a STEMI. We go through the artery in the leg, and under x-ray guidance, we're able to see many of the blood vessels, and we go past the heart, up to the aortic arch, select the blood vessel that's blocked in the brain, and we have knowledge of what might be blocked based on the CT scans we performed in the emergency room after you all bring the patients to the hospital. And so we target that blocked blood vessel using our catheters and FDA-approved devices such as the stent retrievers, which is like a retrievable stent, which is being deployed now across that blockage. And then after waiting approximately 60 to 90 seconds, we basically, it's like going fishing. We remove the blood clot from the blockage in the brain, blocked artery, and then we do another injection with contrast to see if that artery has indeed opened up. And this treatment has been seen to be so successful in clinical trials, randomized control studies, that as of 2015, it became the standard of care for acute stroke patients suffering from a large vessel occlusion. And so overnight, it basically transformed our field, and we started educating paramedics and EMS agencies of how they could best help us to triage these patients to the most appropriate stroke center. Now, what about patients that have bleeding in the brain? And, as I mentioned, I'm not going to go into detail on this. This would be for a future, teaching on hemorrhagic stroke, but simply the way we manage these patients is also by going to the cath lab, but instead of opening up the blocked artery in the brain the way that animation showed, if it's from a ruptured aneurysm causing a bleed in the brain, then our goal is to seal off the aneurysm as quickly as possible by, again, going up through the same arteries from the artery in the leg, and more recently over the last couple of years we're also going through the artery in the wrist, and we navigate up under x-ray guidance. We locate where the aneurysm might be, and we seal it off with coils or stents or flow diverters. There are many different treatments that can now be done to seal off aneurysms in the brain in an urgent manner. And so, coming back to pre-hospital stroke care and the role of paramedics, the reason is important is not just because of the availability of these treatments, but delivering these treatments in a time-sensitive way. So studies have shown that time is brain. Every minute that elapses, about 1.9 million neurons are at risk for irreversible damage in the brain until the blocked artery is opened up. And so we went a step further, and this study is a prime example. In 2017, it showed the results of thousands of patients that were suffering from an acute stroke, And when they were brought in by fire rescue, by paramedics to the appropriate stroke center, and so from time on scene, evaluation by paramedics to arrival to the hospital and arterial access, the way some of these animations showed, and the outcomes of the patients once the vessel was opened up. And so it is very time dependent. And that whole spectrum of care from EMS on scene to triage to the most appropriate stroke center to access and opening up the vessel, the faster that happened, right, the better the outcome for the patient. So here on the y-axis, you can see what was the outcome of those patients, likelihood of being independent at 90 days, and on the x-axis, the time lapse from time EMS was on scene. So the shorter that time interval from EMS on scene to arterial access in the hospital, the higher the likelihood of a patient being independent at 90 days. And so this drives home the point why paramedics are critical in the evaluation of stroke patients, determining that a patient is suffering a stroke, measuring that the level of deficits on the RACE scale or the FAST-ED scale or the LAM scale, some of the newer scales that evaluate for large vessel occlusions, and then triaging them to the most appropriate stroke center so that time is not lost and the artery can be opened up as quickly as possible. So I just wanted to show you briefly how important EMS, their work has played in reducing our time to treatment in our health system. So you can see here that from arterial arrival to the hospital to arterial puncture in the cath lab, when we have a pre-hospital stroke alert, which is the green bar, right, we're able to get door to puncture within that golden hour of stroke care. But without the EMS stroke alert, the red bar, it takes us about 30, 40 more minutes, okay? And data has shown that for every 15 to 20 minute delay in getting the artery opened up, the likelihood of a good outcome reduces by about 20%. So you can imagine for health systems that are not well integrated with paramedics, with local EMS agencies, and if they have, say a 60-minute delay, 90-minute delay from arrival to the hospital to artery being opened up, as a result of absence of an EMS stroke alert, that patient, is going to do a lot worse, right, than a patient who's taken to the cath lab quickly as a result of an EMS stroke alert, early mobilization of the cath lab based on a high RACE scale that's, supplied by EMS, and that patient essentially leaving the hospital many times, without any neurological deficits in a matter of a couple of days. Now, what about for IV TPA? So the door to puncture is for mechanical thrombectomy, the treatment I just showed you. For IV TPA, the clot busting medicine given within 3 up to 4.5 hours, it's the same thing. So if EMS is, sending us information that, okay, there's John Doe coming in, 55-year-old with, RACE scale of XYZ, and we're about 10, 15 minutes away from your hospital, we're going to mobilize our CT scan team, the pharmacy team, the emergency room team, the acute stroke team, the neurologist, the stroke nurse practitioner, and hence the door to needle time, meaning door to IV TPA being given, is only 25 minutes here at Memorial. And without an EMS stroke alert, the time essentially doubles. And so, just want to kind of reinforce why our work with paramedics is so important. And then it's also understanding where to take the patient. And understand that at least in New Jersey, you have the benefit of taking patients to predominantly comprehensive stroke centers in your region. But not all regions are built the same. In South Florida, we have many primary stroke centers, thrombectomy capable stroke centers now, as well as comprehensive stroke centers. So, with primary stroke centers, their main capability is to deliver the clot busting medication, IV TPA. With thrombectomy stroke centers, which is in between now a PSC and a CSC, they can give IV TPA as well as provide the mechanical thrombectomy treatment in the cath lab. The one thing that they're not able to do that a comprehensive stroke center can provide is also treat the bleeds, such as a ruptured aneurysm, bleed from really high blood pressure, because the differentiator is that a CSC has 24/7 neurosurgical capability. So we can take the patients to the operating room, decompress the brain by doing a craniotomy, relieve the high intracranial pressures. So essentially a CSC, a comprehensive stroke center, is the cream of the crop. They have 24/7 capability, manage all types of neurosurgical, neurointerventional issues, whereas a thrombectomy capable stroke center can give IV TPA as well as open up the artery in the brain if it's blocked using mechanical thrombectomy. And a PSC, which is the most common type in the country, are the ones that can give IV TPA. So let's say a stroke patient goes to a primary stroke center and they realize after doing the imaging that this patient not only is suffering a stroke where they can give TPA, but they also need additional treatment, such as mechanical thrombectomy, because a CTA showed a large vessel occlusion. Then essentially that patient has to be shipped out to a thrombectomy capable stroke center or a comprehensive stroke center. And that's time lost, right? Because the interfacility transfer from a PSC to a CSC, the data still currently shows that it takes door in, door out time is approximately upwards of 2 hours. And so the more EMS can recognize that, okay, this might be a suspected large vessel occlusion stroke in the field, instead of going to a PSC, you now have the option of triaging to a thrombectomy or a comprehensive stroke center directly and bypassing a PSC. And so, in your region, it sounds like, again, because of the availability of comprehensive stroke centers, that you're not, facing that type of scenario or dilemma. But, those in rural areas, those in even suburban areas elsewhere in the country, where there's a mix of PSCs, TSCs, CSCs, we've educated paramedics to, if it's within 30 minutes of, from field to a CSC, to bypass a PSC and go straight to a CSC. And all of this is now ingrained in the American Stroke Association Mission Lifeline guidelines, where EMS is at the forefront. And we have all these triage algorithms that educate EMS medical directors and the chiefs and captains on how to triage acute stroke patients if you suspect a large vessel occlusion, the worst type of stroke. And so this is just an example. If you're in a urban or suburban region and you suspect a LVO as a paramedic, and if you have a CSC within 30 minutes max transport time, then to always prioritize going to a CSC. Any questions about triage?
No. No.
Okay, excellent. So now let's get into sort of the most important part of the teaching, which is the pre-hospital assessment. So some of you mentioned, the BFAST or LAMS, and so those are the scales that paramedics should absolutely know, especially the BFAST. If none of the other ones, BFAST is very important. It's, teaches very quickly the kind of straightforward signs and symptoms that a stroke patient might be experiencing, and allows us to flag a possible stroke patient and call in a stroke alert. And then we'll go into the RACE scale and why that's important. So it's balance, eyes, face, arm, speech, and the importance of time. So the balance in eyes refers to the posterior circulation. As I was mentioning earlier, that's the cerebellum responsible for our balance, and the eyes, the occipital lobe, as well as the brainstem, controlling our eye movements, and the occipital lobe responsible for our vision. And so if you see a patient in the field where they're, ataxic, meaning imbalance, or they have a visual field cut, where they're not seeing part of their left side of their visual field or the right side, or their eye movements when you assess them are off, where they're not looking, tracking your fingers, as you ask them, okay, look to the left, look to the right, and if they have any disconjugate gaze, meaning that when you ask them to look one way, one of their eyes is looking elsewhere or not moving at all, then that is a tip off that it could be a posterior circulation stroke. And then face, arm, and speech primarily refers to anterior circulation symptoms, the area of the brain supplied by the carotid arteries. So any droopiness, asymmetry of the face, flattening of the nasolabial fold, the arm, so either a drift of the arm or not moving the arm at all, and speech, inability to get words out or understand what you're saying to them, or slurring of their speech, any of that, should trigger a stroke alert. And so when we go out in the community and teach residents, especially assisted living facilities or nursing homes, the be fast is what we always teach them. And for paramedics, we go into some of the large vessel occlusion skills. And in terms of the hemorrhagic stroke, and I mentioned that, we'll focus just a little bit on this. In the field, the overall deficits, can be very similar to an ischemic stroke, but the key differentiators are because bleeding in the brain causes immediate high pressure in the brain, the patient might become somnolent, they might be drowsy, lethargic, quickly progress to a comatose state. And they may have, accompanying nausea, vomiting. And so those are classic for a hemorrhagic stroke, in addition to weakness on one side of the body or another, or gaze preference and things like that. So let's say you see a patient in the field that had sudden onset, the family may say, or the patient may say, worst headache of their life. Okay, so 10 out of 10, headache, and then followed by quickly headache, neck stiffness, nausea, vomiting, and then progress to a comatose state. That should be a flag for a bleed in the brain, either from a ruptured aneurysm or super high blood pressure. So when you collect your vitals and you see that the blood pressure is, say, above 200, and now with a constellation of these types of symptoms, such as worst headache of life, then it's most likely due to bleeding in the brain. And your goal is to essentially stabilize that patient, make sure their airway is well protected, and keep the head of bed at 30 degrees to make sure that the intracranial pressure is not high, which, when they're completely supine, flat in the stretcher, then it can increase the pressure in the brain. So always head of bed 30 degrees. And if the blood pressure is, say, 220, just to lower it to, say, around, 170s, 180s. You don't want to bottom out the blood pressure, because in the event that this is due to a blockage of an artery in the brain, then by lowering the blood pressure aggressively, you might be hurting the brain by, allowing it to lose the collaterals, the compensatory mechanism to bypass the clot and keep supplying the area that's affected, that penumbra in the brain. And so, those are kind of key ways to manage these types of patients. We would not know for sure until the patient arrives to the hospital and we do a CT scan that, okay, is this due to a blockage of an artery in the brain, or is this due to a bleed in the brain? But I feel that this is one area that is very instructive, and educational for paramedics to understand, and sometimes to, even help them triage patients to the most appropriate stroke center. Because if you suspect that this could be a bleed because of worst headache of life, kind of classic ruptured aneurysm symptoms, and the patient is progressing to a comatose state, then it's more important that they get triaged to a comprehensive stroke center rather than a primary or thrombectomy capable, because those stroke centers are unlikely to be able to safely manage these patients appropriately, because they usually need neurosurgical intervention. So any questions about hemorrhagic stroke?
No.
Okay, good. And so now going into the race scale, so this is a vast majority of the times, and again, let's say you don't know the type of patient, you're encountering. It could be ischemic or hemorrhagic, meaning blockage of an artery or a bleed in the brain. And, either way, you want to objectively quantify their level of neurological deficits. And so it's an extension of BFAST or LAMS, where you want to, actually give it a numerical score. And what differentiates RACE and FAST-ED from the traditional EMS pre-hospital stroke scales is that it also allows you to evaluate for cortical signs. So what do I mean by cortical signs? Those are the areas of the brain that the RACE scale or FAST-ED evaluates that are at the surface of the brain, the functions of the cortex. And so, again, going back to, sort of the way we describe this to our, lay people or, folks when we give talks in the community, it's like plumbing 101, right? You have the pipes that supply the blood to the brain, and if the pipe has a blockage, say near the skull base, then it's the surface of the brain, the cortex, that is going to be most deprived of blood flow and hence oxygen, right? And so those cortex, the cortical parts of the brain, are the speech, the areas responsible for awareness, your surroundings, as well as your eye movements, such as, being able to voluntarily control your eye gaze to the left or to the right. And so the speech is the frontal cortex. The ability to comprehend what others are saying is the temporal lobe, the temporal cortex. And then the gaze center, meaning ability to control eye movements voluntarily and in a conjugate way, look to the left, look to the right, is again the frontal lobe on each side. And then the vision is the occipital lobe, which RACE scale does not assess. And that's one of the limitations I'll go into in a few minutes. And so starting from the top, you have, the ability to assess a facial droop, your arm strength, your leg strength, and then going into the cortical signs. So the face and arm are very similar to the traditional stroke scales, such as Cincinnati or Lamb's. And then the cortical signs is the extension that, RACE and FAST-ED are capable of. And so that's your eye movements, your speech, as well as the awareness around you, the agnosia. And when there's a deficit in that is what we call neglect. Okay. And so we'll go into each of these next. And how does that relate to what we evaluate on the NIH stroke scale score? This is the physician assessment when a patient arrives to the hospital. And that's a 40 plus scale. And the reason the RACE was developed is because it's much shorter. It's only a 9-point scale. It's easier and faster for paramedics to quickly perform in the field, whereas the NIH stroke scale assessment takes, upwards of maybe 5 to 10 minutes, depending on how experienced you are. Where a RACE scale assessment should only take a couple of minutes, depending on, level of experience. And so we've created a RACE scale training video that we deployed via YouTube and sent out to all of the agencies in our South Florida Tri-County region, Palm Beach, Broward, Miami-Dade. So you guys can also refer to it. Everything I'm going over today is mentioned in the RACE scale training video. And so what we did is we took the RACE scale and we separated it into two different parts. So as I mentioned earlier, face, arm, and leg function. So that's your motor strength, right? So, the muscle strength of the face, arm, and leg. And then the cortical signs, which we highlighted in blue here. And again, this is the biggest advantage and differentiator between traditional scales and RACE is the gaze deviation, the speech, as well as awareness around you and awareness of your own body parts. And so let's go into this in a little bit more detail. So when you see a patient in the field, and let's say the patient is down on the ground, and after the initial ABCs, and you make sure that they're stable from an airway, breathing, circulation standpoint, and you begin your stroke assessment, let's say the family says, it was sudden onset, symptom onset was 5 minutes ago, last seen normal time. So you want to log that as, okay, what time were they last seen normal? because that's very important for determining whether a patient is going to be a candidate for IV TPA when they arrive to the hospital. Next, you want to determine, some of the other things such as blood glucose level, make sure this is not a stroke mimic, and I'll give you some other examples of that in a second. And then are checking their vital signs, seeing if they're like super hypertensive, blood pressure of 220s, could be a suspected bleed, like we discussed earlier. And then you start your race assessment. And you basically first observing the patient, from the foot of the bed, once you have them on the stretcher, and you're saying, okay, is the patient looking primarily to the left or to the right? And that's going to determine how you start your assessment. So let's say they have a gaze to the left and their head is turned all the way to the left. Then you want to go to their left side, because if they're turned this way and you start your assessment and you're, on the right side of the stretcher and the patient's looking the other way, they're not going to recognize you and, able to aptly, promptly follow the commands that you're asking them. Always go to the side that they're looking. And that way they see you. There's a higher chance that they'll acknowledge you compared to if you're on the other side of, where their head or gaze is deviated. So next, you want to simply observe after you've gone to the appropriate side of the stretcher, ask them to smile, are they able to, properly form the crease on either side of their nose, what's called the nasolabial fold. So you can say, show me your teeth, or show me a smile. And
February 12th, I can't wait.
sorry, somebody speaking?
No, you're good. Go ahead, sir.
Okay, good. So you want to assess the symmetry of their face, and that's graded on a 1 or a 2. So if it's just slightly asymmetric, then it's a 1. If it's a complete flattening of their, face on that side and you don't see the crease at all, then it's a 2. Okay, so that's pretty straightforward. And you can even ask, like, can I see their driver's license, just to compare, that, okay, this is off from their baseline. Next is the arm function. So again, standing on the appropriate side of the stretcher, you can say, raise your arm, and you want to ask them to raise it up, at least 45 degrees, and keep it up. So you want to keep prompting them, because one of the things that, might commonly, these patients experience is trouble with comprehension. So you want to simulate while you're verbally prompting them, raise your left arm, keep it up. Now, let's say they're not raising their arm at all, then you want to go ahead and lift it up for them. And then once you start prompting them, let go. Okay, you don't want to assist them at all. And then ask them, keep it up. And you want to start counting, up to 10 seconds, 1, 2, 3, etc. And if their arm starts to drift, but it doesn't hit the stretcher at all, then it's basically a 0, okay? That it's normal to mild, that they're able to sustain it for 10 seconds, even with a slight drift, but overall, they're able to keep it completely anti-gravity for a full 10 seconds. Now, what if you count to 10 and their arm, drops all the way down within that 10-second period? Then it's a 1, okay? That essentially they have moderate weakness, and severe means they're not able to raise the arm up at all. So let's say you raise them, and before you even started counting, their arm just collapses, okay? So no movement against gravity is a 2. So that's the most severe. Any questions about arm strength?
No, sir.
Okay. And you want to test one arm at a time. You don't want to, test both arms at the same time, because, they might have altered mental status, confusion, and this way you also isolate each limb and you're testing it, its strength independent of the other. Then the leg strength, same thing. So, ask them to lift up the leg, and then you're going to count. The main difference is up to 5 seconds, and the leg should be about 30 degrees off the stretcher when you're starting to count. If they're not able to lift it at all, then it's 2 points. If they're able to lift it, but it drops within that 5-second count, then it's 1 point. And if it's just slight drift or it's completely normal, they're able to sustain it, then it's 0 points, okay? And then you go on to the gaze preference. So now begins the assessment for cortical signs. So again, it's your observation first, that if their head or their gaze is forced to one side, then that's automatically 1 point. Now, let's say they're looking straight at you, and hence you don't know if they have a gaze or head deviation yet, then ask them to follow your finger with their eyes while keeping their head still. And so you say, follow my finger to the left, to the right, and if they're able to track it consistently and cross midline to each side, then that's normal. But let's say you're here and they're able to track it to the right, and then you come back to midline, but they're not able to go to the left and cross midline, then that means that they have a right gaze preference, okay? So does that make sense?
Yes.
So it comes in all severities. It could be a forced gaze, or it could be something where they're able to look to that side, but then they're not able to cross midline and look to the other side. And so that means they have a gaze preference to the right side, all right? And the way that works is you have frontal eye fields on each side of the brain. And so during a stroke, when one side gets knocked out, the patients automatically have a gaze preference to that side. So always remember, in a stroke, you look to the side of the stroke. So if they have a gaze preference to the right side, that means their stroke is most likely on the right side of their brain, and the motor strength is always to the opposite side. So the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. And so let's say they have a gaze preference to the right, that means that they're most likely going to be weak on the left side, all right? And the only time that where the gaze is opposite is during a seizure. And so that's one of the stroke mimics. So in a seizure, the gaze is to the opposite. So if the seizure is happening on the right side of the brain, they're going to have a forced head and eye deviation to the other side, all right? But in those situations, you still are just going to evaluate the patient like you do normally, and you just say, this is what I'm seeing, and then it's up to the physician when they arrive to the hospital to figure out, okay, is this a seizure or a stroke, all right, based on imaging studies. Next is aphasia. So the speech, you want to, assess both components, the expressive, meaning ability to get words out, and receptive, meaning ability to comprehend what others are saying. So getting words out is the frontal lobes on each side, and understanding what others are saying is the temporal lobe. And so you can basically, have a consistent questions that you're going to ask them so that, you can keep it, kind of concise and efficient when you do the assessment. So I usually say, can you close your eyes? Or can you show me thumbs up? Or can you make a fist? Can you stick out your tongue? Those are all things that, assess whether they're understanding what you're asking them to do. And in those situations, if you're asking them, show me thumbs up, show me a fist, anything that involves the limbs, make sure you ask on the unaffected side. So when you've done the arm strength and you found that they're really weak in the left arm, you don't want to ask them to show you thumbs up on that side, because then it might cloud your assessment. Ask them to do those things on the normal side, okay? So then for, making speech, you can say, repeat after me, today is a sunny day, all right? Or what is your name? What year is it? Who's the president? Anything like that. You can say, hold up a pen. What is this object called? If you're wearing goggles or, eyeglasses, you can say, what am I wearing? What color is my, scrub top? Things like that. So any questions about that? And how is that different how is aphasia different from dysarthria? So dysarthria is slurring of the speech, whereas aphasia is actually inability to get words out, okay, or understand what others are saying. So when I'm assessing a patient, if everything is normal, both expressive and receptive, then they get a 0, right? No deficits. Moderate means that they got some questions wrong in either modality, either the expressive or the receptive. And severe means that they can't follow commands and they're not able to get words out. So they have expressive and receptive aphasia, and therefore they get 2 points. So you might see a patient in the field where they're just completely mute, meaning they're not saying anything, they're not getting words out, and they're not following commands. And so therefore that's automatically 2 points, okay? However, those are the most difficult patients to examine because they may not be able to, follow your arm strength and leg strength assessment as, quickly, right? Because if they're not understanding what you're saying, then they're going to have a hard time, when you ask them, okay, hold up your arm or hold up your leg. And that's why you have to keep prompting them and do it for them in the event they have receptive aphasia. And so by, simulating, mimicking, as well as verbally prompting them, you're going to be able to discern whether they have true weakness, whether versus they're just not doing what you're asking because they have receptive aphasia. And that's one of the most common, mistakes I see paramedics making is if the patient is mute and they're not doing anything, they automatically just, when they call in a stroke alert, they say, "Doc, they're not doing anything on exam. They're not lifting their arm, leg. They're not even answering any questions. So I gave them a race of 9." Okay. And then when they arrive, they're perfectly able to hold up their arm and leg, just through verbal cues and simulating and prompting. But they basically have expressive global aphasia, expressive and receptive aphasia. And you can have that. You can have isolated stroke just in the frontal temporal lobe due to one branch of the artery being out from the middle cerebral without any of the motor function being affected. The last component is the cortical signs of agnosia, meaning, awareness of the surrounding world as well as your own limbs. So what do I mean by that? So if they're suffering a stroke, they may not know, especially if it's in the parietal lobe, which is where the agnosia function, awareness function is, that there's anything wrong with them. So for example, if you hold up their arm, and especially once you've determined they have weakness on one side of the body or the other, if you hold up the arm that's affected and you ask them, and let's say they have a gaze to the left, you want to hold it up where they can see it. If they have a gaze to the left, they're likely to have weakness on the opposite side of the body, like we just discussed. So you have to cross over and hold it up and say, do you recognize this arm? And do you feel that there's any weakness in your arm? If they answer no to either of that no, I don't recognize my arm, and no, I'm not weak in that arm, then that's automatically 2 points. If they answer that, yes, this is my arm, but no, I'm not weak in that arm, then that's 1 point. And if it's completely normal, meaning they're aware of that something's wrong with their limb, their arm weakness, and they know it's their arm, then it's 0 points. Make sense? Okay. So aphasia and neglect is something I want you guys to practice, frequently to make sure you are elucidating the correct responses and the, measuring their deficits appropriately. And not to confuse aphasia with dysarthria, meaning slurred speech, because that's, again, a common mistake that, they're slurring their words, so that means they're aphasic. That's completely separate, and you will grade that, as just their speech being off, okay? So any questions? Okay, so race is a total of 9 points. And if they have cortical signs, what we've instructed our paramedics here in South Florida is to put a plus sign next to the numerical score. And that means that when you're calling in a stroke alert to the receiving hospital, it immediately tips them off that, okay, they have, high level of suspicion for a large vessel occlusion, because cortical signs equal higher probability that it could be a large vessel occlusion. Because of the involvement of the cortex, the surface of the brain, where blood tends to be most deprived in the setting of a large vessel occlusion, meaning a major artery as it arises from the skull base. Okay, so here's an example of a suspected stroke patient in the field with a low race score. And so here, let's say it's 55-year-old, you first do your ABCs, you determine last known well time, they're within 3 hours, so i.e. most likely a candidate for IV TPA, unless they're on blood thinners or recent surgeries, any contraindications for TPA. And you've ensured that, otherwise their vitals are, stable, they don't need any immediate management for any arrhythmias. And now you begin your assessment. And one thing I'll also add is always make sure you have 2 18-gauge antecubital IVs placed in the field, because when a patient arrives to the hospital, we need adequate IV access to perform the CT and CTA, which I'll show you in a second for the in-hospital workflow. So now going back to the race assessment, you start your assessment by mainly observing the patient from the foot of the bed. And in this situation, you've determined that they're not, gazing to one side or the other. So in that situation, you can go to either side of the stretcher. Then you ask them to smile. You notice a slight flattening of their nasolabial fold, the facial asymmetry. You grade that a 1. You ask them to raise their arm up, and they're not able to keep it up for a full 10-second count. So you grade that a 1. Same thing with the leg on the, left side or the right side. And so then you do the, rest of the assessment. You ask them to track, follow their eyes to the left and to the right. They're able to cross midline on both sides. So no gaze preference or head deviation. They answer all the questions correctly for speech and comprehension. And so 0. And they're, aware when you lift up their arm on either side that it's their arm and that they have no weakness. And so hence you get a 3. So most likely, this is what we call a small vessel stroke, meaning it's one of those tiny arteries that arises from the major arteries, the side streets, that's causing the, weakness in this patient. Now, here's a patient where it's the real deal, the large vessel occlusion, the most severe stroke that should ideally go to a thrombectomy or comprehensive stroke center. So again, evaluation in the field, you have start at the foot of the bed, and you've determined that, okay, in this situation, they don't have a gaze preference to one side or the other. They're just looking straight. And so you can go to either side, and then you evaluate that, yes, they have a mild facial droop. They're not able to raise their arm or leg at all on one side. And then you start their aphasia and agnosia. So because they're not able to, produce speech or understand what you're telling them, you're going to grade them as severe. And when you hold up the arm that's affected, they're not aware that they're weak in the arm while they understand that it is their arm. So that's an 8+ out of 9. Okay. So in this situation, call it in as both a numerical score as well as, John Doe has cortical signs of aphasia and mild agnosia, moderate agnosia. Okay. Any questions about that? Okay. So what are the limitations of race assessment? And then we'll wrap up in the next 10, 15 minutes. So it underestimates the cortical signs. So what I mean by that is, compared to other scales that are out there, such as FAST-ED, especially, which is another common large vessel occlusion scale, the race scale only gives a point of 1 to, gaze preference. So FAST-ED gives it 2 points, okay? And then in terms of the aphasia and agnosia, it gives it equal points to motor functions such as face, arm, and leg. So essentially, you can have a score above 5, which is typically the cutoff for suspected large vessel occlusion, merely by having face, arm, and leg weakness, 2, 4, and 6 points total if they have severe deficits in all 3 of the motor signs. And that might be a false alarm for the receiving hospital that, oh, this might be a large vessel occlusion, but simply having motor deficits without any cortical signs, it's a low likelihood that they're going to have a large vessel occlusion. Okay, so that's one of the limitations, is it does not give as high a weight to the cortical signs as does fast ED. The second is that race, and this is something we modified on our race assessment, is it only requires aphasia or agnosia evaluation. What I mean by that is if you find that the patient is only weak on the left side, it asks you just to do agnosia assessment. If they're weak on the right side, it asks you to just do an aphasia assessment. So it picks the side of the weakness in the limbs and determines, guides you to do whether aphasia or agnosia. I would tell you do both every time. Test for aphasia, test for agnosia. Don't pick based on the side of the weakness, because folks that have weakness on the left side can still be aphasic. Folks that have weakness on the right side can still have neglect. The reason the original race evaluation, the creators of this scale did that, is because in many patients, if you have aphasia, that's typically located, the speech centers on the left side of the brain, and hence it coincides with weakness on the right side. And if they have agnosia, it coincides with weakness on the left side. But there's a lot of, outliers and, scenarios where that is not the case. And so always assess for both. And finally, posterior circulation. So it does not assess for vision. It doesn't assess for drowsiness, sleepiness, or deficits in hand-eye coordination, where you say, okay, touch my finger, touch your nose, touch my finger, touch your nose. If they're way off, there's no way to determine that on the race assessment that this could be an isolated basilar artery or posterior cerebral artery, posterior circulation stroke. And so those are some things that you all may want to add, to your evaluation as part of BFAST, the balance and the eyes, to add that either before or after the race assessment to make sure that you also test for hand-eye coordination, or if they don't have any weakness, to ask them to walk in a straight line, like, heel toe, kind of like drunk driving test, as well as test their vision simply by saying, okay, do you see anything on this side? Do you see my arm moving? Or how many fingers am I holding on this side? And then same thing on this side, how many fingers am I holding? You can cover up one of their eyes and ask them to look, you can wave your arm. Do you see my hand moving? And always start at the periphery and work your way in. You have a higher chance of determining if you have a true visual field cut. And then what are the stroke mimics? So seizures, complex migraines, obviously alcohol, drug intoxication or overdose, any metabolic issues such as hypoglycemia, sugars in the 500s, or hypoglycemia, typically, blood glucose less than, say, 70, 60, you're going to see that sometimes they're very lethargic. If they have a prior history of stroke, they can have, evolution of the same deficits that they had before, or if they have underlying infection like a UTI, they might again exhibit the same symptoms from their prior stroke, or just have some baseline lethargy, altered mental status, confusion, aphasia, things like that. And so always important to inquire, do they have any prior history of stroke? And when you call in a stroke alert, it doesn't matter to us whether the deficits are new or old. On the race assessment, you're still going to measure everything, but you can qualify it by saying that, this is new from their baseline, or this is similar to their baseline, and then hear what's new, such as if they have prior history of stroke and they might be, weak in their left arm, But now if they have new left leg weakness or new speech impairment, then you can tell us that, okay, of the race assessment, this is what's new. Any questions before we go into the in-hospital workflow?
No, sir.
Okay. All right. So when you call in a stroke alert, we want to catch all. That means that because mechanical thrombectomy is now approved up to 24 hours after onset of stroke-like symptoms, as well as wake-up stroke patients, it's all depends on what we find on the CT scan when the patients arrive, and not just an actual physical time clock that, okay, if they're at 18 hours, they're automatically excluded. We want to see how large their stroke might be on the CT scan, and then we'll determine, okay, do they qualify for any interventional treatment or not? And so if the CT scan shows that they already have a massive stroke, then they're likely going to be excluded for any interventional revascularization treatments, the mechanical thrombectomy, to reperfuse their brain. If the stroke is small, and this could be the case that even at 16, 18, 20 hours, but they arrive after onset of symptoms or wake-up stroke, but their stroke is still very small, that's likely because they have good collaterals, meaning the bypass channels that kicked in. It's all part of stroke physiology, along with higher than baseline blood pressures, which has kept the stroke from the wildfire from evolving into very large, and hence they may still be receive some benefit from our reperfusion therapies. Let's say they have fluctuating symptoms. So when you saw them in the field, or when the family called 911, they were found down on the ground and completely paralyzed on one side. But by the time you guys arrive, they're up and moving their left arm, left leg, they're talking again. You still want to call that in as a stroke alert, because it could be that, again, collaterals kicked in, the blood pressure kicked up a little bit. And so even if they have no history of high blood pressure, they now are trying to compensate for that blockage of the artery in the brain by temporarily bypassing it and compensating the affected area, the penumbra. And so we see this a lot where, deficits fluctuate. They're really bad, and then they improve, and then they get worse again. Then they come to the ER, and then they're starting to improve again. And so that's not uncommon. And so, always call it in, benefit of the doubt, because, if we miss a large vessel occlusion, it's going to be very detrimental to the patient. And especially if they don't receive that treatment in a timely fashion. New onset seizure could still be, masquerading as an acute stroke. And especially if they have no prior history of seizures, you can basically assume that, okay, this could be a stroke, because about 6 to 7% of all stroke patients present as a seizure. And then finally, posterior circulation, like we discussed earlier, if they're drowsy, if they're in a coma, that could very well be a stroke in the back of the brain. And those are essentially the worst case scenarios. And it's a life and death situation where if we miss that and the stroke evolves in the brainstem, the midbrain, the medulla, then that patient may never wake up again unless they receive that, interventional treatment in the cath lab in a timely fashion. And so in-hospital workflow is very complex. We have many different teams, the radiology team, neurology team, pharmacy team, the emergency team. We're all working in synchrony to make sure, along with our interventional team, the stroke nurse practitioners, to ensure in each phase of the workflow that a patient is expedited and that minimal time is lost until they receive IV TPA if eligible, as well as reperfusion, the thrombectomy treatment in the cath lab. So this is just to show you all the different providers and teams that we have in the hospital, and again highlights the work of paramedics, because when you call in a pre-hospital stroke alert, we essentially activate all of these teams at the same time. There's an overhead stroke alert that, system that we have. We say EMS stroke alert, and that way we know that there's a stroke coming in by EMS. We all converge in the ER, and begin to, assess the patient as soon as he or she arrives. And so this is a, trackpad that we have at Medcom in the emergency room with our race scale log, the last known well time, is a patient on any blood thinners, and what's the ETA for EMS. By logging each of these, we're able to essentially track for quality improvement purposes what else we need to teach paramedics, right? So we want a race scale on each and every stroke alert. We ideally want a last known well time, especially if there's family who can provide it. Is the patient on any blood thinners, because that determines candidacy for IV TPA? And are you 5 minutes away from the hospital, 20 minutes away? Because that also allows us a sense of urgency that, if you're only 5 minutes away from the field, then, you're going to be in the ambulance bay quickly. We want to go ahead and get set up as fast as possible. When the race score is 5 or higher, especially with cortical signs, we give our cath lab a heads up. During after hours, we do a pre-hospital stroke alert to, utilize that to make sure that the cath lab knows that there's a potential, real large vessel occlusion stroke arriving. And so we've also set up FaceTime evaluation with our paramedics in the ambulance. So especially new recruits, where if they need some guidance during their stroke scale assessment, then they can FaceTime me 24/7, and I am able to evaluate these patients right there, from the hospital, from my house into the ambulance. It's a quick 2-minute assessment that gives some level of confidence to the paramedics that, all right, this is a real deal. And it's not disruptive to me. I find it helpful because I'm able to educate paramedics in real time. And, once they get the hang of it, after a couple of stroke alerts, it's not something that they're calling me for every single stroke alert. And then with our parallel workflow, essentially the blue bar here is the progression from fire rescue to the hospital, CT scan, determining what the scan shows. By 30 minutes, we want to give the clot busting medication, if they're eligible. And then by 60 minutes to the cath lab and start the intervention if they have a large vessel occlusion. So this is the progression of our team. In the red lines here, communication is key among our team members, and then converging in the cath lab to begin the treatment. And so this is a CT scanner where we all meet up. This is our stroke hub in the ER. So the CT and sometimes the MRI, but majority of the time, it's only a CT arteriogram. And this is why we want the, 218 gauge antecubital IVs, so that one IV we can use for the CAT scanner to inject the contrast, look at all the blood vessels in the brain, the other IV to make sure that we can simultaneously give the clot busting medication when they're eligible. So we have our algorithms set up and posted in the CAT scanner, which is our stroke hub. So when to do a CTA versus when to do an MRI. Once the patients get to the cath lab, we have 2 techs, 2 nurses. We quickly set up. We allow ourselves 10 to 15 minutes from time patient arrival to arterial access. So it's just like, it's organized chaos, like a NASCAR pit stop, where everybody knows their roles and responsibilities. We practice this using mock stroke codes so that they know what to do when an emergent, case arrives. So this is all hands on deck with our entire cath lab team. You can see getting the patient ready. In the foreground here, you can see our interventional toolkit with our catheters and devices. So as soon as a patient is draped and ready to go, we start the arterial access and intervention. So just to finish up, I'm just gonna run through some illustrative cases. So it's all about time, right? Once a patient arrives, is a golden hour of stroke care. And what we really wanna see here is essentially the patient, going seamlessly across the different phases that I just showed you. So when I hear an EMS stroke alert, for instance, this patient, 74-year-old, left arm leg weakness, was a race scale of 8 or 9 by Hallandale EMS down here in South Florida, and had a blood clot that you can already see on the CT scan. It was 5:30 when she arrived. By the time she was in cath lab, it was, basically about 25 minutes later, got the clot busting medication simultaneously. The vessel was opened within 1 hour of arrival to the ER. That patient left the hospital a couple of days later, essentially normal, without any deficits. And so we create posters like this, or now we share them using WhatsApp. We have an EMS for South Florida group where we have every EMS agency in the Tri-County region with their chiefs and medical directors, where we share cases to highlight, the critical role that EMS plays within 24 hours of finishing a case. This is a patient that complete blockage of the artery in the brain. So I'm going to start here on the left-hand panel. And so this is the worst case scenario where the carotid artery in the neck, as I was showing you, is a common place where plaque builds up. So first, we had to intervene by putting a balloon up and a permanent stent. So we got the entire artery opened up from the neck all the way to the brain. Then when we did the injection in the brain, you can see here the catheter within the orbit area. It's deeper in the brain. And there's another abrupt cutoff. There's no blood flow to this entire part of the brain. So we then opened that up, and now it restored blood flow to the entire left hemisphere. And that patient, within minutes began talking right there on the table, moving their right arm, right leg. And many times paramedics get to witness this because we have them join us in the cath lab to watch these procedures. And the next patient is actually one that, I think for EMS community down here in South Florida hit close to home. This is Eric Jacobowitz. He's a firefighter and a paramedic, and he was working out at the gym. This was last year, and he collapsed and had sudden onset of left-sided arm leg weakness, had gaze preference to the right. He's only in his late 20s, and so the causes of stroke most likely, could be like a carotid dissection, like a tear of the artery in the neck. And when he arrived to the hospital with EMS stroke alert, our cath lab team was already activated. By 12:10, he had already received the clot busting medication because pharmacy was on standby. And by 12:58, within 1 hour of arrival to the hospital with an EMS stroke alert, the artery was already opened up, and he left the hospital a few days later. This is him when I saw him in clinic, completely back to normal. So it's very gratifying. So power of EMS education outreach is real. And that can be demonstrated by, just continuously sharing cases, educating paramedics just the way we are today. And that keeps them in the loop as to, what we're doing in the hospital, how important their role is in the pre-hospital phase. This is a group of paramedics that joined us in the cath lab for a stroke case at 2 a.m. This is us going out to EMS stations here in South Florida and doing our quarterly education for new recruits. And this is during Stroke Awareness Month in May every year, where we go out to EMS stations and shake hands and thank them for their great work and supply some lunch and do some stroke education. This is, again, during Stroke Awareness Month, we have, at least one stroke survivor event where we invite a dozen stroke survivors along with the EMS agencies and the crews that brought these patients in, and really highlight through patient success stories the critical role that EMS plays, in the work that they do day in and day out. So we've collaborated extensively with EMS World over the past 6-7 years, ever since mechanical thrombectomy came about, and wrote up some articles and, demonstrated some of our workflow and integration with pre-hospital stroke care and how invaluable that is for our patients. So really appreciate your time today, and open to any questions. Thank you.
Do you guys have questions? Because I have questions.
Yeah.
Go ahead.
Yeah, I know we focus a lot on the race scale here. Is there, here we use maybe Fast or Cincinnati. Should we focus more now on like the race? Is this like the best stroke scale that we can use with our possible stroke patients, like when we go assessing them?
Yeah, it's a good question. Every region in the country has different policies and protocols, and sometimes is guided by, say, the EMS medical director or countywide, you know, um, uh, policies and procedures versus at the state federal level. And so I would defer to what your region has chosen. What I can tell you is the importance of at least integrating a large vessel occlusion scale beyond Cincinnati, and that includes some objective numerical, assessment of the cortical signs. So again, the gaze preference, the aphasia, then the agnosia, the neglect pieces. And so the race scale does that really well. The fast ED scale is also been validated to be very reliable for predicting a large vessel occlusion. So as long as you're doing race or fast ED, I would say those are the top two that are being utilized around the country. Another one is called VAN, VAN. And the main difference there is that it does not include a numerical scale. It's just a van positive or van negative. And so the one benefit of van compared to race or fast ED is that it does include assessment of vision and ataxia that the race and fast ED do not. But again, as long as you're testing some with some scale that includes cortical signs, it's really your choice or your county's choice which one you decide to do. I would say race and fast ED would be the top two.
So from my experience, the recommendation is to do the BFAST first. Once that shows positive signs, then we move on to the race scale and calculate the race. That's
Yeah,
typically
and
what
that's
we're doing
perfect.
for our agencies. Yeah, that was actually one of my questions. Is that something that you are in favor of? Do you have an opinion of that process? And I think you basically answered that anyway.
Yeah, absolutely. I think BFAST is a good screening tool where let's say on the BFAST scale everything is negative, meaning they have no impairment of balance size, their face, arm, speech is completely fine. Then it's low likelihood that this is going to be a possible stroke. And however, if BFAST screen is positive, then yes, evaluating with race to also include cortical signs such as the gaze and the agnosia and neglect piece is critical because then the receiving hospital can determine stroke severity. Because with BFAST, the branch points are, is this a stroke? Yes or no, suspected stroke. If it is a suspected stroke, yes, then the race allows you to then grade it on a scale of, 1 through 9, and 9 being the most severe type. And as we discussed, anything 5 or higher raises the likelihood that this is a suspected large vessel occlusion.
Thank you. Anybody else have a question? Go ahead, Marcia.
For the race scale, is the reason why you say out of 9 because if it's the right side that we're suspecting, then we go aphasia, and then if it's the left side, we go agnosia.
Correct. So traditionally, that's how race was designed is, if it's once you do your motor assessment, the arm and the leg, and if it's left-sided weakness, then you assess agnosia only. And if it's right-sided weakness, then you assess aphasia only. What I'm advocating for is assess both aphasia and agnosia. And it's okay, if you get a score that's therefore higher than 9, you just tell them that, look, qualitatively, I'm getting, I have a patient that can't produce speech or not following commands or both, as well as not aware of their, weakness or their body part, i.e. the neglect component.
Thank you.
Good question. Anybody else have a question? Okay, I actually have a couple. I've written a lot of notes too. So
Sure.
you mentioned the use of blood pressure lowering medications. Where do you see that in pre-hospital? Because everything that I've been reading over the last probably 15 plus years, we don't want to lower the blood pressure in the field. I don't know if I haven't seen any recent studies, but it's not because I'm looking. And I wanted to know if you know of anything that's coming down the trail for us in the pre-hospital world to start lowering blood pressures, or is that something that we should continue not to do?
Yeah, I would say, follow your current pre-hospital guidelines until there's, something formal out there. One thing, what we all, have trained our paramedics down here is that if the blood pressure is, say, above 220, then it's reasonable to lower it, to around 180. Because once a patient comes to the hospital, let's say they're determined to be eligible for IV TPA, and if there's no bleed on CT, the cutoff for giving TPA is blood pressure less than 185 systolic and 110 diastolic. And hence, we have to lower the blood pressure. And, for a stroke, if it's due to a blockage of an artery in the brain, yeah, we don't want to bottom them out, as we were discussing earlier. So the guidelines currently for in-hospital blood pressure management acute stroke say, recommend not lowering by more than 20 to 25% in the first 24 hours, and reasonable to just lower it to make sure that they're at least less than 185 systolic to ensure that, eligibility for IV TPA. And so it doesn't cause any harm in the pre-hospital phase to, if the blood pressure is 220, studies have shown that very high blood pressure, especially above 180, 190 equals worse outcomes, and very low blood pressure also equals worse outcomes. So it's really that middle range is where we want to keep that blood pressure optimized.
Mm-hmm. Yeah, because right now the practice is we're not lowering the blood pressure in the field. For the most part, we have shorter transports to the hospital, and they're typically enacting that protocol in the hospital, bringing their blood pressures down to 180. What medications are you using primarily to lower the blood pressure? What are the paramedics in Florida using in your area? Just out of curiosity.
Yeah, so typically first line, for us is cardine and then labetalol. So cardine is very fast acting, nicardipine, and, just a small bolus like 1.25 to 2.5 milligrams IV allows us to quickly lower the blood pressure, especially when we're considering patients for IV TPA, and the blood pressure is, above 185 systolic. And, many times if we see a patient blood pressure of like 200, 220 on arrival, our protocol is to first give cardine, and then if that's not effective after one or two boluses, start an infusion and can simultaneously give labetalol, like 5 to 10 milligrams IV bolus.
Thank you. And then the other question I had was in regard to resource for EMS for pre-hospital. So, the RACE score it's longer than some of the other assessments we do, and unless you do it all the time, it's not something you necessarily have officially memorized, or you can march down that list very easily. Are there any resources, apps, or anything that you might recommend that you've come across that maybe the pre-hospital in Florida are using that you might recommend? I mean, I know there's a few out there, but I just want to see what you thought about that.
Yeah, it's a good question. So there is an official app from the Society of Neurointerventional Surgery, and that, allows paramedics to perform some of the large vessel occlusion scales quickly in the field. So I can send you that link.
Yes.
So that's a popular mobile app. Our Society of Vascular Interventional Neurology has made one in the past. And then there's also one for fast ED that is really good, which I can also send you the link for. And what we did down in our region is we simply laminated the RACE scale assessment, what I showed you with the, cortical signs highlighted in blue, and we had the EMS chiefs put it in all the trucks, and that their way, it's available as a visual reference to them when they're assessing the patient.
Okay, if you don't mind, if I could get that off of your PowerPoint, I can actually make a copy for the students, if that would be okay
Sure.
with you. Would you
Yeah,
be willing
absolutely.
to share your slide deck with me as well, and I can pull that off?
Yes, I'll send you I think I emailed you the Dropbox link this morning.
Oh, you did? Okay, I didn't see it yet. All right, great.
Right.
Yeah, because I would like to share the slide deck with the students, and then what I'll do is I'll take that race score slide you're referencing, that table, and I'll give it to you guys so you have it, because you have to practice that scale, because it's not, I mean, even as a practicing paramedic, I'm not seeing stroke patients every single day, so I'm not using it all the time. So
Right, yeah.
that would be really helpful. That'd be really helpful.
Yeah, absolutely.
Okay. Does anybody have anything else for Dr. Mehta? Yeah, it was this one, but without the red in it, right? Without the
Yes,
binder.
I have, you can use this one, it's in the slide deck.
Yes, that would be perfect. And I can definitely give them a copy. We could even shrink it down to be pocket size. Yeah, that'd be
Sure,
great.
yeah, absolutely.
Cool. All right. Any final thoughts from anybody? Dr. Mehta, students?
Yeah, I know some of the neurointerventionalists in, your county, including, I think, Valley Hospital. And
Yeah, Dr.
so,
Altschul. Do you know Dr. Altschul?
yes. So
Yes.
she's fantastic. She and I actually trained together at Mass General in Boston. So she's, big advocate, for pre-hospital stroke care. And yeah, I'm sure she'd be happy to reach out to you all and do further education.
Yes, so when I was the clinical educator at Valley before I took this job, Dr. Altschul actually did an outreach for me. It's probably 7+ years ago. So I definitely remember Dr. Altschul. She's pretty cool. She's amazing, actually.
Yeah, that's awesome.
And she's very friendly to EMS. So definitely want to
Yeah.
make some connections there with her and Valley, and have her do something with us with the students as well.
Yeah,
thank you.
definitely.
Yeah. But I definitely want, we all want to thank you for your time, Dr. Mehta, and your knowledge. I mean, I wrote pages of notes because I learned something too. So I greatly appreciate your time and everything, all the information you've given to us.
Oh, sure. My pleasure.
Yeah, it's great. Thank you so much. You have my email. If there's anything that we can help you with, of course, please reach out. Let us know if there's something that we can assist with or do something in the future. And also thank you to Josh Hartman. I know he helped us to set this up and make the connection with you. So Josh is an instructor here, so that's how they know him, as Instructor Hartman.
Oh, okay, great.
Yeah, he's one of the adjunct faculty here. So it was huge. All I said was we need some stroke education, and Josh picks up his phone and he knows everybody. So
yeah, that's fantastic. We do a fair bit of work through EMS World. And so I'll be at the Expo, EMS World Expo in New Orleans this year. So we're doing some, stroke education and some sessions. So if you guys see us on the agenda, please feel free to attend.
I will definitely be there, and I will come find you. Absolutely. So we can meet in person. Yeah, that'd be great. All right, Dr. Mehta, thank you so much again for your time. I know the students are appreciative as well.
My pleasure. Thank you all.
Have a great rest of your day, sir. Thank you.
Thank you.
All right.